Hello, welcome. Good evening, everyone who are joining us from all over India. Good morning to those who are joining us from worldwide, everywhere else. We bring a webinar organized by Chest Council of India. Today, we are going to talk about antibiotic decisions in pulmonary infections when we are waiting for the culture report, and this shall be a nationwide experience. We all know a culture report can take 48, 72, sometimes 96 hours. But there are certain new advances, molecular diagnostics, that can bring down the turnaround time to even less. But often in resource limited settings, these molecular diagnostics may be a bit dicey. So, what may be the various empirical decisions, how they have changed in recent, especially post COVID? Has there been any new guidelines, any new evidence? We are going to discuss all that today. And for that, as the motto of Chess Council of India, one for all and all for one, we have a nationwide panel today. We are very fortunate to have a guest speaker, Dr. Farhan Fazal. He has done DM in infectious disease from AIMS New Delhi. Currently, he is based in the UAE as our infectious disease expert. Among pulmonologists, we have from North India, Professor Anand Agrawal works at Sonipat. Recently, he was a hero of a wonderful conducted NatCon in Sonipat, Haryana. So Dr. Anand Agarwal will give us his experience from North India. As we move down to the west, very near the Statue of Unity, we have Dr. Mitesh Dave from Ahmedabad. He is an intensivist and an interventionist pulmonologist working at Ahmedabad. As we move further down, we have Professor Aswini Mohapatra working at KMC Manipal, graduating and post-graduating from the prestigious SCB Cuttack. He is working at KMC Manipal. Then as we move up, we to the central India, when we come to Raipur, we have Dr. Ranjan Kumar Patel. He is an assistant professor pulmonary medicine at Raipur Institute of Medical Sciences. Then when we go to the far east, to the magical city of Guwahati, Assam, we have Dr. Rahul Karwa. He did his MD pulmonary from Guwahati and currently he is working in Guwahati. He is one of the pioneers of advanced pulmonary function testing in the entire Northeast. And I myself, I am based at Ranchi, Jharkhand, Atri Gangopadhyay. I am a freelancer pulmonologist over here. First, we have a presentation by Dr. Rahul Karwa. Dr. Rahul Karwa will tell us a little bit about the subject and then we shall go to the panel discussion. Dr. Rahul, the stage is yours.
Good evening, everyone. Myself, Dr. Rahul Karwa, pulmonologist from Guwahati. Today, the topic of discussion is antibiotic of choice in various illnesses of pulmonology, the empirical antibiotic therapy, waiting yet for the culture report. So, just to give a brief overview, I'll be discussing on the empirical antibiotic therapy in community-acquired pneumonia mainly. Just to proceed with the antibiotics, how can we define CAP? In the absence of a chest radiograph, it is defined as a symptoms of acute lower respiratory tract illness, which includes fever, shortness of breath, cough, pleuritic chest pain, along with the systemic feature like fever, chills, rigor, or malaise, and if there is a new focal chest sign on examination or auscultation, and there is no other explanation. If a radiograph is available, then along with the signs and symptoms, a new radiographic shadowing for which there is no other explanation. As per the IDSA ATS guideline, it is defined as the presence of new lung infiltrate plus evidence of infectious origin. Community-acquired pneumonia accounts for almost around 3.5 million deaths each year globally, making it one of the highest cause of mortality among infectious diseases. The overall attack rate is about 12 cases per 1,000 persons per year. The rate of admission varies from the age group of 17 to 55 years, and it increases as the age group uh, begins to in the elderly population. As per the Indian etiology of CAP, study published in 2006, it was seen that Streptococcus pneumonia was the most common organism for the CAP, followed by Staph aureus and Klebsiella pneumonia and H. influenzae. In the Western population also, it was Streptococcus pneumonia, followed by Mycoplasma and H. influenzae. As per the chart shown in this graph, it can be seen that the Streptococcus pneumonia accounted for around 42% in one study from Kerala in 2009. And the Streptococcus pneumonia prevalence ranges from around 3% to up to 40%. The incidence per 1 lakh population increases as the age group progresses, and also if there is a chronic lung disease, the underlying condition, the relative risk increases up to 7.7 times. So, what leads to community-acquired pneumonia? It can be seen that the probable positive immigration factors, which include the supine position, proximity to oropharynx, dependent anatomy, laryngeal dysfunction, if there is a gross aspiration, which can be seen in a stroke patient or debilitated patients, bedridden patients, poor dental hygiene, then gastroesophageal reflux. And the negative extinction factors include if there is decrease in cough reflux, there is endobronchial obstruction, impaired ciliary function, etc. The most common clinical signs and symptoms includes the presence of cough, may or may not be associated with expectoration, fever, dyspnea, pleuritic chest pain. The frequency of each symptom is variable, and elderly may not manifest the classical clinical features. As per the guidelines, the chest radiograph, wherever feasible, should be obtained in all patients suspected of having CAP. If a patient has responded to the antibiotic, a follow-up chest radiograph is not recommended. And in the absence of availability of chest radiograph, patients may be treated on the basis of clinical suspicion. Chest radiograph is to be repeated if the patient is not improving or there is a persistence or worsening of symptoms. Blood culture is advised to be obtained in all hospitalized patients with CAP. In the routine outpatient management, it is not recommended. Initial sputum stain, gram stain and culture should be obtained in hospitalized patients. Sputum AFB should be obtained as per RNTCP guidelines or NTEP guidelines for the patients. Legionella urinary antigen and pneumococcal antigen detection is routinely not recommended in the management of CAP in outpatients. The risk stratification, the three major which are usually used are CUP-CC5, which is easy to implement. There are 5 points: confusion, urea, respiratory rate, blood pressure, and age. 1 point is awarded to each. If the score is 0 to 1, usually oral antibiotics and home isolation, home treatment is advised. If the score is more than 2 or 2, then hospital admission is advised. And if it is more than or equals to 3, then usually supportive care and ICU admission is advised. There is another index which is a pneumonia severity index, which includes demographics, comorbidities, physical examination of vital signs, and laboratory and imaging. And the ATS IDSA criteria is usually used for to define severe CAP. The two major criteria includes the shock and requirement of mechanical ventilation. invasive. And the minor criteria includes respiratory rate, PO to FiO2 ratio, infiltrates on the X-ray, then confusion or disorientation, uremia, leukopenia, thrombocytopenia, hypothermia, and hypertension requiring aggressive fluid resuscitation. So what is the role of biomarkers? The most common used biomarkers include CRP and procalcitonin. So as the value of the CRP increases, the specificity increases. Similarly for procalcitonin, without a chest X-ray, the diagnostic accuracy is usually somewhat less as compared with a chest X-ray, as shown in the graph. The specificity increases if it is associated with infiltrate on a chest X-ray. Antibiotics should be administered as early as possible. Timing is more important in severe CAP. Initial empiric and treatment, most likely etiology, then local antibiogram pattern if it is available, pharmacokinetics of drugs, compliance and cost and safety, and if there is any history of recent antibiotic use. Usually, to cover atypical organisms, it is not required in mild disease in OP setting and required in patients with comorbidities like immunocompromised chronic diseases of heart, lung, liver disease, or renal disease. And if there is a history of antibiotic use in previous 3 months. Outpatients should be stratified as those with or without comorbidities. The recommended antibiotics include oral beta-lactams or oral macrolides. Fluoroquinolones is usually not advised to be used for empiric treatment in Indian guidelines because of the prevalence of TB and the use of fluoroquinolones as a drug in management of TB. As per the IDSA ATS guidelines, if there is no comorbidities or no associated risk factors for MRSA or Pseudomonas aeruginosa, the standard regimen may include amoxicillin or doxycycline or macrolide. And with comorbidities, the combination therapy of beta-lactam plus macrolide or doxycycline, or can be monotherapy with respiratory fluoroquinolone. In the inpatient treatment, if the patient is admitted but not in ICU, the combination therapy of a beta-lactam plus macrolide is preferred. The preferred beta-lactams include cefotaxime, ceftriaxone, or amoxicillin clavulanic acid. If there is a sensitivity to beta-lactam, respiratory fluoroquinolone may be used. If the patient is admitted in the ICU, the recommended regimen is a beta-lactam plus a macrolide. In macrolide, azithromycin is preferred as can be given intravenous or parenteral if there is no associated risk factor for Pseudomonas aeruginosa. If Pseudomonas aeruginosa is an etiological consideration, an antipneumococcal anti-pseudomonal antibiotic like cefepime, ceftazidime, or piperacillin tazobactam or carbapenem should be used. Combination therapy may be considered with addition of aminoglycosides or anti-pseudomonal fluoroquinolones. This was the joint ICS NCCP guideline in 2012. As per the IDSA ATS 2019 guidelines, in inpatient treatment, if the pneumonia is non-severe, the standard regimen includes beta-lactam plus macrolide or a respiratory fluoroquinolone. Similarly, for inpatient severe pneumonia, beta-lactam plus macrolide or beta-lactam plus fluoroquinolone. MRSA coverage is recommended if there is a prior respiratory isolation of MRSA and previous history. Similarly, for Pseudomonas aeruginosa, if there is a prior respiratory isolation of Pseudomonas aeruginosa, then add coverage for Pseudomonas aeruginosa and send samples for culture. If there is a recent hospitalization and use of parenteral antibiotics, then obtain cultures. And if there is a locally validated risk factor for MRSA, then cultures has to be sent but withhold the MRSA coverage unless the culture results are positive. If rapid nasal PCR is available, then withhold additional empiric therapy against MRSA if rapid testing is negative. If there is a recent hospitalization and there is a locally validated risk factor for Pseudomonas aeruginosa, obtain cultures but initiate coverage for Pseudomonas aeruginosa only if culture results are positive. Why the beta-lactam plus macrolide combination is preferred? Because coverage of white organisms also atypical, survival benefit with combination therapy. It also gives anti-inflammatory effect on host immune response. And immunomodulatory effects include disruption of biofilm formation, inhibition of quorum sensing, inhibition of protein synthesis, and reduced bacterial adherence and motility, increase in mucociliary clearance, and inhibits inducible nitric oxide synthesis. Thank you.
Thank you, Dr. Rahul. Wonderful introduction. You spoke so beautifully about CAP, and not only CAP, we are going to discuss multiple infections in pulmonary today. And yeah, CAP is definitely something very major. As we start our panel discussion, my first question is to Dr. Farhan, our infectious disease specialist. As we were seeing that sometimes we need to give combination of antibiotics. So can you kindly enumerate a few antibiotics in pulmonary medicine combinations which are not good combination and cause more harm than good? Dr. Farhan.
Yeah, thank you so much for the invitation, first of all, and for the question as well. Regarding the pulmonary infections, I think the most important one which comes to my mind is in aspiration pneumonia. I've seen a lot of places where patients are put on a cocktail of clindamycin added to any other antibiotic. So what we need to understand is any kind of infection, our target is to understand what is the most probable organism, what is the antibiotic that is most commonly going to cover the organism, and what dose and duration are we going to give it. So many times you see that the patient is on a cocktail of amoxiclav plus clindamycin, or ceftriaxone or peptidazobactam with clindamycin, or meropenem plus clindamycin. What we need to understand is that pipentazobactam, amoxiclav, and meropenem, all of them have good anaerobic coverage, in which case we do not need an addition of clindamycin. So I think from a combination perspective, this doesn't make any sense. Also, when you're going to add two different group of antibiotics, like say azithromycin and levofloxacin, so addition of these two antibiotics for a community-acquired pneumonia also doesn't make any sense. It is much more simpler to follow in community-acquired pneumonia the strategy of beta-lactam group antibiotics plus an azithromycin or a levofloxacin to cover for the atypical organisms as such and for the anti-inflammatory effect.
Yeah, why this question came to my mind was that often marketing agents come with certain combinations, quinolone and a ornidazole, quinolone and a tinidazole. Sometimes they come with a certain combination, cefixime with azithromycin. Then any oral cephalosporin, they combine it with clavulanic acid. Some of them should not be combined. So that is why it's very important to know which combinations are a strict no-no. From
Plus, we
Dr.
also need to
Farhan, now
understand, just to add to that, we also need to know that we should be trying to do evidence-based medicine, not marketing-based medicine, and that sometimes creeps into the system because lack of knowledge and plus the pressure. So I think these cocktails should be avoided. As it is in any diarrhea patient, even the pharmacist will give you O2 tablets or tablets which combine ofloxacin and ornidazole. I think that cocktail should strictly be avoided. And our idea should be to get to the bottom of the diagnosis and the organism. And I'm sure we'll be discussing in the coming few minutes as well.
Yeah. My next question to Professor Anand sir. We have a CAP, community-acquired pneumonia, in an OPD setting, outpatient setting. Kindly tell us the appropriate empirical antibiotic of choice and optimum duration as per latest evidence.
Yeah, this is a very good question actually, which you have asked. There are two aspects. If we talk about the community acquired patients having no comorbidity like diabetes, mellitus, hypertension, and other, we can give only a single antibiotics as per recommendation by the American Thoracic Society, that is amoxicillin and clavulanic acid. But we can also give some other medications like azithromycin, or we can give the doxycycline. But preferably, we should give the amoxicillin and clavulanic acid. We can give it 1.2 1 gram 8 hourly or TDS. We can give it. But if the patients have comorbidities like diabetes mellitus, or the patient having some renal failure, the obesity may be there, so we should generally combine the drugs, not a single drugs that we prescribe. Beta-lactam along with the macrolides is a preferable choice. We can give amoxiclav along with the azithromycin or clarithromycin. Somehow, if patients have cardiac ailments, like if macrolides are not indicated and we can't provide the macrolide, then in that case we can give the doxycycline to the patients along with the beta-lactams. So cephalosporin can also be used along with the doxycycline. So these are the medicine which can be prescribed at OPD setting where the comorbidities are there.
Thank you. I would want to move to Aswini, sir. After COVID, lots of people consult pulmonologist even for upper respiratory tract issues. So if there are patients with acute upper respiratory tract infection, or let's say acute pharyngotonsillitis, what may be the antibiotic of choice, or where may antibiotic not be needed in such situations? Aswini, sir.
This is a very common question. Actually, we are facing a problem in related to our practice, especially after the COVID pandemic. So OPD is flooded with acute URTI, acute pharyngotonsillitis, all these stuffs. Basically, to say acute URTI is a viral infection, antibiotics is not required for treating acute upper respiratory infection as it is a viral in origin. But when it is complicated by secondary bacterial infection, antibiotics does have a role to play. Of course, and you can see in acute URTI, 5 to 15% of the patients also have got associated Streptococcus pyogenes, and for that treatment is also required. Coming to the second part of the question, the treatment of choice in case of acute pharyngotonsillitis. Again, acute pharyngotonsillitis is a viral infection, whereas an acute bacterial pharyngotonsillitis, it is a bacterial infection. So acute bacterial pharyngotonsillitis is caused by an organism that is called Streptococcus pyogenes, and antibiotic coverage is definitely required to treat acute pharyngotonsillitis. So there is a scoring system that is called modified Mentor score or a MAC-IJAC score. If the modified Mentor score is more than equal to 3, and you can suspect that patient is having a associated Streptococcus pyogenes infection. So if you get such a patient of acute bacterial pharyngotonsillitis with a modified center score more than equal to 3, you can suspect a Streptococcus pyogenes infection. And how to treat that patient? The antibiotic of choice is amoxicillin. It has to be given 50 milligram twice a day. The maximum dose is 1 gram per day, or you can give 25 milligram per kg body weight twice a day, and the total duration of therapy is almost 10 days. Suppose if the patient is allergic to amoxicillin, then you have to go for other routine stuffs like first generation cephalosporin. You can also give benzathine penicillin also. So in total, this covers the treatment regarding acute bacterial pharyngotonsillitis.
So one message which is very clear in the last 10 minutes is, despite whatever resistance patterns, if there are uncomplicated respiratory cases, stable patient, maybe amoxicillin will do the trick in over 80% of patients. So please remember, dear friends, that whatever we read about resistance, If the patient is stable, if you're confident that the patient does not need admission, maybe you should stick to something which is almost a century old now, that is amoxicillin. Old is gold definitely works here. When I'm talking about gold, I would want to go to Dr. Mitesh Dave. Gold, COPD, India #1, largest disease in the world, so many things. So our COPD patient coming with CAP, would you want to go with whatever we do, or is there any changes? COPD patient with CAP, antibiotic management. Dr. Mitesh.
Right. Thank you so much, Dr. Atri, and good evening to all. So basically, when we talk about any empirical choice of antibiotics in any situation, what we basically decide is what are the probable microorganisms which we are expecting in that particular population. And on the basis of that, we can decide the empirical choice of antibiotics. Now, as far as COPD is concerned, it has been found that the organisms responsible for pneumonia in COPD patients are similar to those which are found in generalized community-acquired pneumonia. That is, Streptococcus pneumonia being the most common. Except for the fact that the patients who have been frequent exacerbators, the patients who have been having recurrent admissions because of COPD exacerbations requiring multiple antibiotics multiple times, they tend to harbor more of gram-negative bacilli like Pseudomonas, Klebsiella. So according to me, when I approach a patient of COPD with community-acquired pneumonia and I need to start some empirical regimen, I would like to prefer the antibiotics which would cover both, that is the normal strep pneumonia plus a gram-negative coverage. So I think a beta-lactam inhibitor like amoxicillin, clavulanic acid, along with if there is a Pseudomonas expectation, that is a frequent exacerbator is there, we might need to add aminoglycosides or fluoroquinolones in the same regimen. So that would be my particular choice in the COPD exacerbated patients due to pneumonia.
Thank you. We would want to move to
can I just add a couple of points?
Yeah, Dr. Farhan, please.
I think it's very important to understand for the common public as well that exacerbation of COPD is different from pneumonia in a COPD. Many times what happens is, like doctors was suggesting, that a Pseudomonas coverage should be given. That is to be given only when you're really thinking of a pneumonia, not just a COPD patient who comes with increased breathing difficulty, increased expectoration and cough. That exacerbation could just be because of Moraxella and atypical organ or viruses per se, in which case just a doxycycline or azithromycin would be enough. What we see commonly is that a COPD patient comes with exacerbation, gets admitted, chest X-ray is clear, there's no pneumoniac patch. Just because the WBC count is 11,500, the patient is then put on ceftazidime plus aminoglycoside plus something else. So I think it's very important clinically to differentiate an exacerbation versus a pneumonia, which an X-ray and clinical picture should really be helpful. And even exacerbation should be.
Yeah, the question basically is pneumonia in COPD patients. And aminoglycosides only we add when we suspect, like if it is a frequent exacerbator, there is a past history of isolating Pseudomonas in the culture, there is an obvious patch on the X-ray. Otherwise, a beta-lactam inhibitor is more than enough. Beta-lactam antibiotic is more than enough.
Thank you. I would want to move on to Dr. Ranjan from Raipur. Dr. Ranjan, let us talk a little bit about immunocompromise. Immunocompromised patient with pneumonia at presentation, empirical antibiotic. Mind you, this is in general. In our further question, we will move to each aspect of immunocompromise. Dr. Ranjan. Please unmute yourself. Kindly unmute. Yeah.
Thank you. Sorry. Immunocompromised patients without any additional risk factors for drug-resistant bacteria can receive initial empirical therapy targeting only the core respiratory pathogens like the immunocompetent. So, before starting empirical therapy in immunocompromised, we should know the risk factors for MDR infection. The risk factors are present hospitalization for more than 5 days, high frequency of antibiotic resistance in local population, hospitalization for more than 48 hours in last 3 months, home infusion therapy, including antibiotics, home wound care, chronic dialysis within 1 month, a family member with MDR infection, and patients on immunosuppressive drugs or therapy. So these patients with risk factors of MDR infection should be upgraded with MRSA or Pseudomonas coverage. Because in Indian population, gram-negative infections are very common, we should cover with Pseudomonas or beta-lactamase producing, ESBL producing gram-negative bacilli with piperacillin tazobactam 4.5 gram 4 times daily, or cefoperazone sulbactam 3 gram twice daily, or ceftazidime or cefepime cefepirone, and also penems can be added if patient is not improving. In combination therapy, like combination of amikacin and fluoroquinolones can be added for improvement of patients.
Yeah, thank you, Dr. Ranjan. Very exhaustive. And we shall move into each immunocompromise in detail. Before that, we shall move on to Dr. Rahul. Dr. Rahul, kindly tell, when we are talking about oral antibiotics has to have a relation with gastric absorption. So please guide us a little regarding a relation of oral antibiotic with empty stomach, full stomach, etc.
Good evening, everyone. Usually, the most common antibiotic which we have been talking is about the beta-lactam. So, amoxicillin or amoxiclav is usually preferred at the start of meal, and it should be avoided with a high-fat meal because it delays the absorption of the drug. And for cephalosporins in general, it can be taken with or without food. But cefaclor is an oral antibiotic which should be taken in a fasting state and not with food. Then moving to other antibiotics like the doxycycline, it is usually, all the antibiotics usually should be avoided and not to be taken with other drugs at the same time. And especially for then like iron supplements, if a patient is taking or calcium supplements, multivitamin or gastric like suspension, because it acts with the acidity of the stomach and it will delay or less the bioavailability of the drug. Then for other common antibiotics like macrolides, it can be taken 1 hour before meal. Then for other antibiotics like metronidazole or trimethoprim, they should be taken after food.
Thank you, Dr. Rahul. Very interesting. These small things help a lot in curing a patient or causing treatment failure. Half an hour into the panel, we already have around 6 or 7 audience questions. So I would want to ask Dr. Anand Agrawal. Dr. Yogesh Kawane from Pune, Maharashtra has asked a question. Basically, he's stuck with a case and he wants our help. What could be antibiotic of choice for left lower lobe pneumonia with bronchiectasis in 85-year-old male smoker patient? Dr. Anand, your expertise, please.
Yeah, if the patient is having the pneumonia with bronchitis, having a smoker also, so the chances of pseudomonal infection is Hello, am I audible? Hello,
Yes.
am I audible?
Yeah, we can hear
Yes.
you.
Hello. Yeah. In case of bronchitis along with the COPD, or we can say if the patient is smoker, the chances of the pseudomonal infection is very, very high. So in that condition, we should prescribe the medications which are actually required to cover the pseudomonal infections. So in that case, if the patient comes in on a PD basis, then fluoroquinolones is a good along with the amoxiclav. But if we talk about the serious patients, those who are admitted, where if pseudomonas should be covered, we should add the piperacillin tazobactam or the beta-lactam, which have the sensitivity for the pseudomonal coverage. So we can add pseudomonal coverage like piperacillin, tazobactam, talactam, along with the amikacin. So that will be more beneficial. Or we can add the fluoroquinolones also in that condition for a shorter period. Though we know fluoroquinolone is a reserved drug and that should not be misused. But in case of bronchiectasis, pseudomonal infection may be high. So we can add it for a shorter period like 1 week. That is recommended.
Thank you, sir.
Can I just
Whenever we
sorry?
talk,
Can I just
yeah,
add
Dr.
here?
Farhan, please
Sorry,
add.
doctor. Yeah.
Please add.
Yeah, this is just to add on that, of course, guidelines are there to help us to select the appropriate antibiotics. But how I would approach this is to understand what is the clinical scenario of the patient and what's the window of opportunity you have got to be wrong. Suppose this patient is in the ward with 1 liter or 2 liter of oxygen. You could just start off with just one antibiotic, wait for the cultures and then move on. And the same patient is in the ICU, ventilated, on an intubated, then of course you would be more aggressive and add 2 antibiotics, pseudomonas coverage, where you don't want to be wrong in terms of coverage. So again, the decision making would also be dependent on where the patient is at this point. Is it in the ward, is it in the OPD, or is it in the ICU? And that would decide the aggressiveness of the of your treatment. Simply because the number of hours you have got to be wrong is lesser if the patient is in the ICU.
Okay. Yeah. Now we have a question for Dr. Farhan. Whenever we are talking about antibiotics, penicillins, beta-lactam, cephalosporin take up a huge family. So can you tell us about some bacterial species which are intrinsically resistant to this entire beta-lactam group, and what may be and how we may identify them without a culture empirically?
Right. So the beta-lactam group of antibiotics work on the cell wall. So all the organisms do not come up on gram stain or don't have the cell wall are the ones which will not work, which will not be affected by beta-lactam. So the atypical organs that we talk about, that is the mycoplasma, chlamydia, and Legionella. These are the organisms which are not affected by beta-lactam group of antibiotics and therefore are associated, and therefore we have to add an atypical coverage in community-acquired pneumonia. Now, second part of the question, how do we identify these? Again, it has to go back to clinical scenario. Suppose a patient is from a small outbreak with Legionella, where everybody comes with the same respiratory illness, then Legionella can be thought about. And our old clinical medicine, where patient has diarrhea, patient has hyponatremia, will give a clue towards Legionella. If the patient has got, say, bird exposure, then chlamydia becomes more likely. If the patient has got hemolysis, is very sick, then mycoplasma also becomes a possibility. So these are the clinical cues. But at the end of the day, these clinical cues are not very sensitive nor specific for identification of the organism. Hence, the empirical choice first. So you start giving the antibiotics, hope that one of them comes positive either in your pneumonia panel or the cultures, and then based on that we can escalate or de-escalate. Most of the time, what happens is we end up giving both beta-lactam antibiotics and azithromycin, and after the 5 days, patient gets better, and patient goes home. That's what the usual story is. But again, if you haven't used a atypical coverage in your cocktail of antibiotics, then this is the right time to add it upon.
Thank you. We have an audience question for Dr. Aswini, and he happens to be an old friend of yours from medical college. Dr. Sudarshan Pothal from Puri is asking that often we note about past history of use of antibiotic in last 3 months. So what is the scientific basis of this 3 months? Why it is 3 months? Why it is not 45 days? Why it is not 6 months? Aswini, sir.
Yeah, hi, Dr. Pothal. Thank you for the question. Actually, I don't have much idea about the thing, but what I presume that 3 months is a period where patient has to be reassessed again. Basically, I don't have any idea on this question.
Anyone else can help in this question, that why there is a cutoff of 3 months when we ask history of past use of antibiotics? Any scientific basis for the same?
It's just based on studies where any kind of study that you do, when you try to figure out why somebody had a Pseudomonas infection, the likelihood of the person having previous history of antibiotic use is going to be higher in comparison to somebody who did not have Pseudomonas infection. Now, why this 3-month line is cut off is because, I'm presuming again, is because most of them were in the first 3 months. Again, if you collect data and say it is 67th day or 92nd day, it wouldn't. It's more difficult to collect data in such regard. So therefore, the authors must have selected a date. Okay, we are going to take less than 1 month, less than 2 months, less than 3 months. The same argument goes when you're doing studies for COVID. They would say 30-day mortality, 60-day mortality. Why not 45? Why not 43? Why not 35? So again, I think this is just ease of administration of doing studies.
I agree with Dr. Farhan. I think this is arbitrary
please.
cutoff.
Dr. Atri, actually, there are certain guidelines which are associated with the fluoroquinolones, where it is recommended it should not be given more than 1 month. I'm not sure about the 3-month strategy, but I'm sure that 1 month antibiotic should not be given to the patients, because if 1 month antibiotic or the fluoroquinolones would be given, the chances of resistance with the fluoroquinolones is very, very high. There are a lot of studies which has been published. So 3-month criteria is not applicable everywhere. So it depends on the type of antibiotic which you are using in the cases.
Yeah, guideline
So
is there for
basically
1
to
month only.
translate, so basically to translate, what I presume is that after eradicating an infection, let's say 2 to 3 weeks, growth of flora, establishment of flora takes a period of approx or median 3 months. So maybe that's why they took it as 3 months. My next question is to Dr. Mitesh. When we are encountering cases of lung abscess is something we can diagnose on an X-ray and very typical clinical features. What is the current antibiotic choice in lung abscess? Dr. Mitesh.
Right. Now, again, with any other condition similar here, what we are expecting, which microorganisms we are expecting, they will guide the choice of empirical antibiotics. Till date, lung abscess, the most common cause is aspiration. So the oral organisms, that is anaerobes and microaerophilic streptococci, those are the common organisms. If we talk about the pathogenic bacteria, we have Staph aureus, we have gram-negative bacilli like Pseudomonas klebsiella, and then rare like nocardia or Burkholderia, and then non-bacterial causes like fungal TB, etc. So basically, when we are targeting an empirical therapy in a case of lung abscess, I think we would like a broad spectrum antibiotic with a good anaerobic coverage. So I think a beta-lactam inhibitor, along with which has a good anaerobic coverage like piperacillin tazobactam or cefabrazone sulbactam would be a good choice. If gram-positive is also suspected, we might go on to add linezolid along with this regimen for the empirical portion of the treatment, for starting the treatment. Later on, the cultures can guide us.
Thank you. Dr. Ranjan, we have an audience question for you. Dr. Trideep Chatterjee from Mumbai, he is a regular listener of our webinars, and he wants to ask is, in pneumonia, or let's say severe pneumonia, when would you want to send a BAL or a sputum for biofire panel and routine aerobic culture? Would you want to do it in all patient or in which patient? How do you justify?
Sir,
One, regarding bronchoscopy BAL, second, regarding biofire, third, regarding routine cultures.
Sir, first, routine cultures is advisable in all admitted patients. If patients are admitted, then before starting antibiotics, we should send some sputum samples. But if patient is not producing good quality sputum, and then we like to send for BAL samples. And regarding biofire panel, because the turnaround time is very less, like the reports are available in 24 hours. So if patient is sick and we need early reports, then these PCR studies can be sent.
Dr. Rahul, when he was doing his MD pulmonary medicine, He had the experience. He was one of the first doctors in India who had used bedaquiline in DRTB because he was a PG resident and his college was 1 out of 6 in India at that time. So suppose our DRTB patient who needs medicines for 12 months, 18 months, 24 months, this DRTB patient has suffered a community acquired pneumonia. So what may be our antibiotic selection, keeping in mind that the patient is already on so many anti-TB medicine and the patient, due to a long history of TB, may be having some structural lung damage also. Dr. Rahul, kindly guide us.
In a DRTB patient, since the patient has already taken ATT and will be on a multiple course of antibiotic, if a patient is suspected to have pneumonia, and along with the structure, keeping in mind the structural lung damage which may be present, it would be good to start with a combination of antibiotic like a beta-lactam and a macrolide. If there is a proper history, then we should evaluate the history, which antibiotic the patient has not used previously. That would be a better choice. And if there is a good sample production, then after starting the combination of antibiotic, we should send the sputum sample for culture sensitivity. And azithromycin will be a choice of macrolide along with the beta-lactam. If in outpatient setting like amoxiclav or cephalosporin, but if a patient is has to be admitted, then depending on whether the patient is inpatient in a ward or ICU, then injectable antibiotic would be preferred.
Thank you. We would want to move to Dr. Aswini now. Suppose there is this patient of pleural effusion and after tapping, the fluid comes out to be pus, or this is a case of empyema. So we send something, a empyema profile or a culture. So what may be the empirical antibiotic in empyema as per current evidence?
This empyema can be a community-acquired empyema or it can be a hospital-acquired empyema also. As you talked about the patient, he had a pleural effusion and aspirated and frank pus is there. So in case of a community-acquired empyema, the antibiotics should target the common pathogens which are lying in the oropharynx. And the common pathogens are Staphylococcus aureus, Streptococcus species, and anaerobes. So the treatment of choice in a case of community-acquired empyema is a beta-lactam plus a beta-lactam as inhibitor, that is amoxiclavulinic acid plus piperacillin or piperacillin tazobactam. Whereas in a case of hospital-acquired empyema, you have to give a coverage for a associated Pseudomonas species. So that treatment of choice for a hospital-acquired empyema should be either a vancomycin plus piperacillin tazobactam or a beta-lactamase producing organism. So it depends what is the setting of the empyema. If the empyema has come from a community-acquired pneumonia, the antibiotics is different. And if the empyema is from a hospital-acquired patient, the antibiotics protocol will little change. So in a hospital-acquired setting, you have to give a more gram-negative coverage, plus you have to add anti-pseudomonal coverage.
Thank you. Nowadays, even earlier and even today, staph aureus is something very notorious. And one of the evidence to prevent or minimize staph is always hand washing. But even despite so many measures, sometimes we encounter staph, and not sometimes, almost every day. So Dr. Farhan, could you kindly guide that clinically what may be a clue towards the MRSA and what is the current antibiotic of choice for MSSA and MRSA?
Right. So the first question is, what are clinical pointers for staph infection? So
MRSA.
like previously, yes, MRSA. So previously, as mentioned, that if anybody has prior MRSA colonization, then that becomes a big risk factor. If somebody has skin involvement of infection with skin lesions which are affected by MRSA, that becomes a risk factor. From a clinical point of view, what is important is if the patient is post-influenza or post-viral illness. So anybody who comes with pneumonia saying that first 2-3 days the patient had fever, running nose, and then on the 6th or 7th day, the patient has developed pneumonia. This is a good marker that there is a good possibility that there is going to be staph aureus. Now, whether that staph aureus is going to be MRSA or not, community-acquired MRSA or hospital-acquired MRSA, is a difficult question to answer. Regarding the choice of antibiotics for MSSA and MRSA, for MSSA, simple amoxiclav or amoxicillin should be easily working. In Indian context, we have cefazolin, although it's very cheap and very difficult to get these days, but cefazolin is still a very, very good drug. And also we have dicloxacillin or amoxiclav. Simple amoxiclav should be reasonable for using for MSSA. For MRSA, in oral options, we have linezolid, which works for almost everything. But for community-acquired MRSA, even clindamycin should be a reasonable choice. In terms of IV, we have vancomycin. There are multiple studies which are for and against the use of either vancomycin, teicoplanin, or linezolid for MRSA pneumonia. I personally prefer linezolid, and there is reasonably good data suggesting that linezolid is slightly more better compared to vancomycin, plus the headache of not monitoring, therapeutic drug monitoring for vancomycin, as well as the kidney derangement. So I think this is why I would prefer linezolid for MRSA. Simple amoxiclav for MSSA would also be okay.
Thank you. We have an audience question from Tiruvannamalai, Tamil Nadu, Dr. Anand. So I would ask this question also to our Dr. Anand. Dr. Anand from Tamil Nadu is asking you that in chronic neurological patients, CVA survivor, head injury survivor, what is the antibiotic for aspiration pneumonia in chronic neurological patients?
Yeah, exactly. If the patients have neurological disorder, the chances of aspiration is very, very high. So as per guidelines, generally, we don't start any anaerobic treatment. Many a times it is seen that during the aspiration, there is only a pneumonitis. So the gastric content which goes inside the lung that get resolved within 48 hours with the normal antibiotics. There is no need of any anaerobic treatment. But if there are some complications which are associated with the aspiration of the anaerobic pathogens, like lung abscess or the empyema, in that complicated case, we may add the anaerobic treatment like clindamycin. So there are little difference in the guidelines. Clindamycin should not be used as a routine because it may cause the resistance Clostridium difficile. So that's why clindamycin should not be empirically used in such cases. We should wait for at least 24 to 48 hours with the normal beta-lactams as well as with the azithromycin that has been routinely given to the patients in the aspiration pneumonia.
So what I can understand is currently India is suffering from cricket fever, that lot of these 2020 matches are going on. And sometimes some player wants to do something spectacular. Sometimes they succeed, but most of the time they are not succeeding. So what Dr. Anand wants to say is that in such situations, first you please go with the conventional antibiotic. If there are any new star, you wait for 24 to 48 hours before introducing your new star, rather than giving your new star at the very beginning and doing an overkill. Because these patients might require antibiotics for a long period of time, recurrent, something like recurrent. So thank you.
Very practical example, Dr. Atri.
Yeah. And now we move to Dr. Mitesh Dave. There is a question from Gujarat, Ahmedabad, Dr. Sachi Dave. And looking at the same surname and same city, are you both related? You may be related. Is there any role of oral cefditoren in empirical CAP treatment, Dr. Mitesh?
Yeah, sir. So the first question, are we related? Yes, she is my wife. So I think she must be watching the webinar. She is also a pulmonologist practicing in Ahmedabad.
Wow.
So I think that is the answer to the first. The second question, that is basically, is oral cefditoren has a role in empirical CAP treatment? So what we need to understand is basically it is a cephalosporin, later generation cephalosporin. So the coverage is almost the same. That is basically when we are asking to treat for empirical CAP, we need to cover strep pneumonia as a first choice. So I think rather than opting for oral ceftriaxone, the already available antibiotics, that is amoxiclav, which is augmentin is oral available. That is a good enough option. But yes, it can be used for the treatment of empirically for CAP because the coverage is almost the same and a little better. The issue is that it is a costly drug. If you see the cost of ceftriaxone, basically for a 5-day therapy, it costs around something 800 or 1000 or maybe more. So there are cheaper alternatives available, and I think if the cost is not an issue, we can use it.
Thank you. I remember another scenario. Growing up in Ranchi, the only entertainment was Bollywood movies. And when Shan picture was released, the fans were fighting that Amitabh did better acting or Shashi Kapoor did better acting. So similarly, maybe in Gujarat, Ahmedabad, the patients will be fighting that Dr. Mitesh is better doctor or Dr. Sachi is better doctor, whatever. So thank you. Another question for Dr. Mitesh. Antibiotic of choice in CAP in a pregnant patient.
Right. Okay. So basically, when we talk about pregnancy and antibiotics, the first thing which we should look at is the safety. Safety profile of the antibiotics is very important for the mother as well as for the fetus. Now, the organisms responsible for causing pneumonia in pregnancy are almost the similar ones as any other community-acquired pneumonia. The antibiotics, as far as pregnancy is concerned, they are graded into various categories. That is A, B, C, D, and X. A being the least toxic and X being the ones which are contraindicated. Most of the antibiotics which we use in day-to-day basis, they basically fall in the B category. So I think in a stable patient, oral beta-lactam antibiotic like augmentin is okay, or a macrolide like azithromycin is fine. If the patient is toxic or the patient is not stable or indoor, the patient is requires IPD treatment and is toxic, we may need a higher class of antibiotics like carbapenems. Now, or in the stable patients, the beta-lactam or cephalosporins are fair enough. In cephalosporins, the only thing, ceftriaxone is basically avoided in the last trimester because there are chances of chronic stress in the baby and all. Otherwise, like any other regimen, a beta-lactam cephalosporin would be fine for a pregnant females as well. The thing which we need to know is basically what to avoid. Aminoglycosides need to be avoided, fluoroquinolones need to be avoided, tetracyclines need to be avoided, unless we have no other choice. And basically, fluoroquinolones, Leoflox can be used, but with the fact that the benefit outweighs the risk with which we are using it.
Yeah, thank you. I just got a message from our admin that over 900 people are currently watching us live, and that despite some very tense IPL match going on, over 900 people are watching all of us live. So I want to thank all the audience out there that it is your support which makes us work so hard to give these webinars, to give this evidence-based medicine. Thank you to all the audience out there. I would want to move on to Dr. Ranjan Kumar Patel. We have an audience question from you. Dr. Ram Prasad from Chennai, Tamil Nadu. He wants to ask about that when we are talking about carbapenems, there is an oral carbapenem known as ferropenem. So does ferropenem has good coverage like meropenem, aerobic and anaerobic both? Dr. Ranjan.
Sir, although ferropenem has good coverage against gram-negative organisms, usually hospitalized patients are advised IV penems until patient is clinically stable. And once patient is clinically stable and patient is going to get discharged, then it can be given for a few days to complete the antibiotic course of 7 to 8 days.
Can I comment here?
Yeah,
Dr.
please. Dr. Farhan,
yeah.
Please.
First of all, ferropenem is not a carbapenem. It has a penem ring, but it's not equal to meropenem. If it was, then our job in life would have been so much more easier, right? We would just give ferropenem to everybody, and our life would have been easier. So if anybody is under the impression that Ferropenem is oral meropenem? The answer is no, it's not. Secondly, it is not FDA approved for anything. It's still under the trial, and it is probably India and few other countries are the only countries where ferropenem is available. Thirdly, I want to make sure that everybody understands that if you have a ESBL infection or an infection with multi-drug resistance, and you assume that you are going to get away, instead of giving 10 days of meropenem, you're going to get away with giving oral ferropenem, it's going to be a very touch and go situation. It might work, as Dr. mentioned, there is coverage. In vivo, there is coverage, no doubt about it. But whether that can be practically translated to clinical success is going to be a big if. And I have seen multiple people burn their fingers, especially for conditions like melioidosis, where they need long-term antibiotic therapy. People want to be a little stingy and conjuice and try to shift to oral ferropenem, thinking, give us 3 days of meropenem and then 5 days of ferropenem will work. To strictly speaking, it is not a carbapenem. That's the first thing. And secondly, for pneumonia, for pulmonary infection, again, I think there's enough data. Even 3 days of antibiotic is good enough. So if the patient is needing meropenem and if this patient is getting discharged, I would stop the antibiotic and not give anything at discharge. If he is not on oxygen, if he's clinically stable, fever is settled down, I don't think he needs any further antibiotic efforts. Of course, if you say abscesses, lung abscesses, they need prolonged therapy. But again, I would have a big cautious approach to this, where it's a new molecule. The pharma is pushing it, saying that because it sounds like carbapenem, they're pushing it like, why you're spending 3,000 rupees on meropenem when you can get 100 rupees of tablets and then you can give 4 weeks of antibiotics and save at least 1 lakh rupees of the patient. So please be cautious, whoever is using it. I, for one, do not vouch for it. I do not use it and until I get more evidence, because that's what evidence-based medicine is about.
So to translate into colloquial language, we can consider meropenem as hamaropenem, doripenem as dohrapenem, ferropenem as far off penem, and we should just observe that whether biapenem will be bye-bye penem or whether that will also be something acceptable. Similar question was asked by Dr. Samadarshi Datta from Kolkata, West Bengal. Any role of ferropenem in empirical cap? And can we extrapolate the sensitivity of parenteral penem to oral? So I am sure this also answered that question. Similar question was asked by Dr. Jitendra Kumar Shah from Gujarat. When to consider clindamycin? That has also been answered. Now I would want to move on to Dr. Rahul. We asked you another question regarding DRTB. So now we have a TB patient who has been treated, a post-TB sequelae patient with cavity, bronchiectasis, getting recurrent infections. Kindly guide regarding the OPD antibiotic management of the same in post-TB sequelae cavity bronchiectasis. Dr. Rahul.
In a treated TB patient presenting with bronchiectasis having recurrent infections, so the most likely thing would be that a patient might have a sensitivity pattern or organism which was came out to be positive in a previous infection if a sensitivity pattern was done. If it is not there, then we would need to look for whether it is a exacerbation, patient is having recurrent exacerbation of bronchiectasis or it is associated with a infection like pneumonia. Because if a patient is a frequent exacerbator and there is no evidence of pneumonia, then we may go for a macrolide therapy like azithromycin thrice weekly for long term. And in case of acute presentation, if in a OPD setting, considering bronchiectasis, we would go for a dual coverage, which includes macrolide along with a beta-lactam. And if it comes out to be positive for pseudomonas, then the antibiotic coverage would change accordingly. And it would be at least for 14 to 21 days. Similarly, for cavity, if a patient is having recurrent infection, then we should also evaluate for any fungal infection. If a good sample, sputum sample is present, it's fine. Otherwise, we would need to go for a bronchoscopy.
Thank you. I'm getting lots of questions from audience regarding certain interventions, certain antifungal. What I want to tell to everyone over there is today we are only focusing on the empirical antibiotic part. Empirical antibiotic is a very huge, untouched, often misunderstood sector. So today we just want to focus on that. If we take some questions on fungus related, then our discussion will move somewhere else. And maybe our message for today will be incomplete. So those questions we shall take maybe on a future date. Dr. Mitesh, we have audience question for you. Dr. Gopi Krishna from Vijayawada, Andhra Pradesh. He is asking you regarding treatment of VRE, that is vanco-resistant enterobacter. Dr. Mitesh.
Yes. So thank you so much for the question. So basically for vancomycin-resistant enterobacter, the preferable choice of antibiotic would be teicoplanin, which is another alternative for the same coverage. And so,
yeah, you're audible, please.
Yeah. So basically, I think for the drug of choice for VRE would be teicoplanin, according to my side.
Can I just add in even linezolid is a reasonable option.
Yeah, for stable patient, linezolid is a reasonable option, but in like sick patients, the teicoplanin would be a preferable option. The stable patients,
because teicoplanin and vancomycin are similar in nature, there is a possibility that it might be resistant. So if you have a sensitivity, then of course there are a few enterococcus which are resistant to vanco but sensitive to teico. But when we say it is VRE vancomycin resistant enterococcus, there is a good possibility that teicoplanin also will be resistant, and therefore linezolid might be a better choice if you have the sensitivity at that point, because we would not be knowing whether it is vancomycin resistant or not, because that will take time for us to come out and cultures to come out on
that. We have a question from Dr. Mahesh Dev, Kollam, Kerala. He wants to ask Dr. Farhan that kindly guide regarding long-term macrolide prophylaxis in bronchiectasis. What is the current evidence? What should we do currently?
I think there is reasonably good evidence for it. The only downside is the side effects. If you see the criteria or from the ATS also, they do suggest for patients who have got frequent exacerbations and infections in bronchiectasis patients to give long-term doxycycline, and they have tried azithromycin as well. So I think the data is there. The problem in India is resistance to development of azithromycin as well as the side effects. So if your patients can follow up, if your patients can afford it, and you are able to manage the side effects, I think it's a reasonable choice. But you have to make sure that if it's just very rarely does the bronchiectasis cause any trouble to the patient, if they're not having frequent exacerbations, I would then just refrain and treat them when they have the episode. Like suppose once a year the patient comes to you, and the rest of the year the patient is fine. Now for that one episode, keeping the patient in azithromycin and not only having the side effects but also increasing the cost doesn't make really any sense as far as I'm concerned.
Anand sir, you deal with lot of NTM also. You deal with lot of post-TB sequelae also. So when you give this macrolide prophylaxis in bronchiectasis patient, means what is the duration you would advocate, Anand sir?
Azithromycin have dual benefit. The one is antibacterial action and another is immunomodulator. So it also acts as to reduce the inflammation of the airways. So once we start the azithromycin, it can prevent the further progression of the infection. So in cases of bronchiectasis, we can provide it for a prolonged period in a lower dose, like 250 milligram. We can give it for a prolonged period, more than 1 year also, if it is complicated frequently. As Dr. I think Farhan, as Dr. Farhan said, if the patient is not complicated, then there is no need to add any antibiotic, because only the bronchodilator therapy is sufficient. And if there is a frequent exacerbation, then only it is recommended to be prescribed azithromycin or doxycycline for a prolonged period. It may be 1 year or it may be 3 years. There are maximum study for 3 years. After that, the studies was not conducted neither in the bronchiectasis nor in the ILD.
We have an audience question, Dr. C. Suresh Kumar from Kadapa, Andhra Pradesh. Yeah, Dr. Farhan,
can I add
please.
also to these patients who you want to prevent further infections, please focus on vaccinations also. Although the rate of prevention of infection is not 100%, but these vulnerable groups like the bronchiectasis patients and the COPD patients will be very helpful for them if you vaccinated them against influenza, COVID, and now pneumococcal vaccine as well. So I think that point also should be focused on, not just antibiotics, but also vaccination.
Yeah, Dr. C. Suresh Kumar, basically his question is on antiviral, but since currently half of the globe is suffering from this viral, we don't know whether it's influenza, we don't know whether it's a milder form of COVID. So he wants to know about current fate of molnupiravir, favipiravir, oseltamivir. Anyone from the panel?
It has been discarded by the Ministry of Health and Family Welfare that no oral medication should be given to any antiviral ailments except the oseltamivir.
So oseltamivir is in and other two are not in currently.
Again, I would want to jump
Dr.
in
Farhan.
quickly for a comment is that oseltamivir is a good drug, but it has to be given only for those patients who are influenza proven infections. Yeah. Not just everybody who's having running nose and fever, because it should not be empirical. Also, there is some thought process that if the patient has influenza positive and at least 2 to 3 days have passed, then the efficacy of oseltamivir in those patients is not great. Again, those is for those patients who are on the OPD side. But if you admit a patient and he says 5 days back I had fever and now he's in the ICU, there is still some benefit in giving oseltamivir oral, even if the patient is intubated, for that matter. So don't not give oseltamivir in those patients, but also not give anybody with running nose oseltamivir.
There are two things where oseltamivir can be given empirically. The one, if the influenza epidemic has been outbreak in that area, or the person who visit and return back to from that area where this the influenza has been outbreak. So there are two things which has been given in ATS guidelines, recent guidelines. Only in that condition we can prescribe the oseltamivir on empirical basis. Otherwise, we should not.
Thank you. Dr. Aswini is working at Manipal Hospital. Manipal is currently doing a lot of fantastic work in lung cancer, and they are saving lots of lung cancer patients. So a person with lung cancer got treatment, survived. Now this person landed with neutropenia, chemo-related neutropenia. So antibiotic in this lung cancer survivor with neutropenia. Aswini, sir.
Yeah, there's a lot of patients with chemotherapy, they land up with febrile neutropenia. So in those category of patients, one should always cover a gram-negative pathogen along with the MRSA coverage. As far as this febrile neutropenia is considered, you have to give a vigorous antibiotic, taking into consideration these two pathogens. So we can start with a vancomycin or any gram-negative coverage like carbapenem group of drugs. But if you look at the prophylaxis of those patients, because something is called persistent febrile neutropenia, that means the neutrophil count is always less than 100 per cubic millimeter of blood or persistently for 7 days. They are called persistent febrile neutropenia. So in those category of patients, you require a prophylactic antibiotic. Without that, you cannot manage this type of patients. And truly speaking, in case of prophylaxis, in case of chemotherapy-induced neutropenia, the colony stimulating factor plays a very vital role. But they are all expensive agents. So it is not possible in all ways. So you have to give some antibiotics, prophylactic antibiotics for this persistent febrile neutropenia. And the prophylactic antibiotic of choice is always a trimethoprim and sulfamethoxazole. So you can continue these antibiotics depending on the side effects, and you can continue for a prolonged period of time. Some meta-analysis studies have shown that it can be given for maximum for 1 year also.
Thank you. Oh,
Can I
Dr.
can I
Farhan,
jump in,
please.
Doc? Yeah, yeah.
Yeah,
Just to add
please.
on to what doctor has already mentioned, if a neutropenic patient has a pneumonia, it's a very good idea to get a quick CT and try to rule out fungal infection, because you don't want to miss out on a fungal infection. We're trying to target only bacteria, and if you have the opportunity to do galactomannan in serum, if you're able to get that, that's a pretty good high marker in neutropenic patients specifically. And also the pattern on the CT scan would help you to at least consider a fungal infection and to send for sputum for fungal infection, not just leaving the bacteria. As I agree with the antibacterials the doctor has mentioned, that is been to be given, but also don't forget the fungus in neutropenic patients because they will not give you much time to really react.
Thank you. So neutropenia is a condition where anticipate fungus to apprehend the fungus, basically. That's wonderful. So yesterday I had this lady. She is a known case of pulmonary artery hypertension, and she got admitted in the ICU. And today morning her daughter comes and she introduces herself. Say, hello, I am her daughter and I'm coming straight from California. So are you giving my mother prebiotics, or are you giving my mother pre and probiotics both along with the antibiotic? And I was like stunned. So Dr. Ranjan, can you kindly guide us regarding pre and probiotics in antibiotic therapy?
Yes, sir. Thank you. Antibiotic associated diarrhea actually is a very common side effect of antibiotic usage, and it affects up to one-third of patients. And it can occur in patients from starting of treatment up to 2 months of treatment at the end of treatment. But there is no consensus across the globe regarding the recommendation for the clinical use of probiotics for antibiotic associated diarrhea. But patients who have past history of antibiotic associated diarrhea should be routinely prescribed probiotics, and also antibiotics notorious for causing diarrhea. In combination of antibiotics, specifically in comorbid patients, if used, then probiotics should be added. However, routinely in all patients, use of probiotics is not advisable.
Thank you. So to continue my story, I asked her daughter that which profession you are. She told that she is into IT. Then I told, thank God. So you have not heard about the daughter from California syndrome. So Dr. Rahul, can you
Yeah.
kindly tell us that recently, in the last 5 to 7 years, what may be the new antibiotics which have come and what are their spectra?
One of the antibiotic injectable which is commonly used nowadays is ceftazidime avibactam. So it has a good spectrum of activity. Ceftazidime is a third generation cephalosporin, and avibactam being a non-beta-lactam, beta-lactam is inhibitor. But the only thing is that ceftazidime avibactam is not sensitive against Acinetobacter, anaerobes, or Staph aureus. So that we have to keep in mind. It is available in India. Then another antibiotic combination which has come up is a ceftriaxone plus sulbactam plus EDTA. It also gives you a wide coverage, and it is active. It gives coverage against Acinetobacter, also Pseudomonas, E. coli, Klebsiella. So it has got a good coverage, and it's given in. It is available in injectable form. Another antibiotic which has been recently available is levonorefloxacin. It is a benzylquinoline derivative of fluoroquinolone, and it also gives you a wide variety of coverage against gram-positive and gram-negative both. It also gives coverage against some atypical organisms like chlamydia and mycoplasma. So it is available in both IV and oral, and the oral formulation can be given in both fasting or with food. So there is no restriction regarding that. Then other oral antibiotics which are available, one we have already talked is ceftriaxone. The cost is an issue, and also cefaclor has come up. It is a old antibiotic, but recently it is also being promoted, and it has to be given in a fasting state. The cost is also an issue here. So one tablet will cost around 100 rupees, I think.
So one thing is new antibiotic and another thing is rediscovered antibiotic like cefaclor and ceftitoren. They have been rediscovered. Even chloramphenicol to some extent has been rediscovered. So one thing just now came to my mind, that when we are talking about this levonadifloxacin, since it is something of a quinolone derivative, is there any study or is there any discussion regarding trying the same for anti-TB? Can anyone tell? Because levofloxacin is somewhere in anti-TB, moxifloxacin is somewhere in anti-TB. Regarding levonadifloxacin and anti-TB.
So it has got a good gram-positive coverage, that is, it covers MRSA to a good extent. But as far as TB is concerned, I am not aware of any studies where it has been tried.
Dr. Farhan?
Yeah.
Dr.
Can I just jump in? Just jump into the answer to the question regarding the new molecule. Of course, before we go into the trials, we have to see if this molecule has any activity against the mycobacterium. Just jumping in to the comments the doctor mentioned about the new molecule, I just want to caution again. I'm trying to be the bad boy here and not letting anybody use antibiotics. It's because I'm worried about resistance. So ceftazine-avibactam, it's a good molecule, no doubt about it. But please make sure you use it only when it is really necessary and not as an empirical choice. Simply because this is probably the last straw that we have got in carbapenem-resistant Enterobacteriaceae. So don't use it because you like it or if the pharma company is pushing it. Regarding the other molecules as such, the new molecules with ceftriaxone, EDTA, sulbactam, again, the studies which the company had done were predominantly for UTI infections, which was compared with Piptaz and Meropenem, where they had shown reasonable outcomes. For pneumonias and for bacteremia patients, please read the data and see for yourself if you feel that you're comfortable using it, compare it to already best standard. Also, regarding the newer molecule being used for tuberculosis, I think for tuberculosis there are new molecules which already has come into the trials, pretominide and linezolid and all of that stuff. And I think hopefully in the future TB will become much more simpler. Giving just 4 drugs for 6 months will be much more easier for us in the future. But yes, that's the gist of it. So please use antibiotics carefully so that our children have something to play with in the future.
Okay, Dr. Farhan, Dr. Trideep Chatterjee, he is asking you that has there been any change in the treatment of VAP with respect to newer guidelines, especially in post-COVID treatment of VAP, ventilator-associated pneumonia?
Again, the treatment of VAP depends on which part of the world are you staying. If you look at, say, America or European countries where resistance is less, they would still be comfortable using piperacillin-tazobactam. For a country like India, where our ESBL rates, the CRE rates are reaching sky high, every hospital or every part of the country will need to have their own guidelines. If you see the ICMR guidelines, they do suggest to use carbapenems with amikacin plus or minus colistin, or cefaclor sulbactam with amikacin and then plus or minus colistin. So in terms of change in management, nothing has changed. What I suggest is each of us should pledge today that we will go and speak to our wonderful microbiologist. We'll go and ask them, look, give me the data of the last 1 year. What is the Acinetobacter looking like? What is the Pseudomonas looking like? Why this is important is, mathematically speaking, suppose you have a VAP patient and in your hospital there is an 80% resistant to meropenem. That means that 8 out of 10 patients you give meropenem, the patient will not have a good outcome. Now, this information is very important, and this information is hospital specific or geographical specific. So all of us need to go back to our microbiologist, ask them, okay, the Pseudomonas in our hospital, what is the resistance to Piptaz? What is the resistance to meropenem? And what is the resistance to colistin? So only if you know this information, you'll be able to tailor down the regimen. Otherwise, the simple answer is give everybody meropenem vancomycin. That's like the straightforward answer. But that will not hold good in the place that you're working.
Yeah. Dr. Mitesh, we have this LRTI patient with uncontrolled diabetes, because this person may be some belief of faith healing, pranic healing, alternate therapy. increase sugar to reverse diabetes, and so philosophical therapies. So this patient has come with uncontrolled diabetes and LRTI. So what would be your antibiotic management, Dr. Mitesh?
Right, sir. So diabetic patients, it is important to have a good empirical coverage initially. The reason being they have got higher chances of mortality if not being treated properly at a later date. Also, the uncontrolled diabetic patients, they are more prone to harbor more gram-negative as well as MRSA infections. So for any stable patient with LRTI with uncontrolled diabetes, I think the normal regimen of a beta-lactam inhibitor combination is fair enough. If I am suspecting that there has been previous infections with Pseudomonas, some previous admissions in the previous months, I would like to go with a Pseudomonas coverage beta-lactam molecule like piperacillin tazobactam. And especially if I am seeing empymas or I am seeing necrotizing pneumonias, I might consider on adding MRSA coverage, that is linezolid. So that would be my choice of empirical antibiotics in diabetic.
Nowadays, we are moving into the transplant era. Lots of transplant of various organs is happening, and lots of transplant people are surviving. Just yesterday, I saw a photo of a lung transplant survivor doing a trek in the Himalayas, and that was something very happy. So, Ashwini sir, please guide us regarding some antibiotic decisions in transplant survivors, solid organ transplant, especially lung transplant.
There is a huge thing in case of solid organ transplant. Actually, I'm not going into that in detail. I will just focus on a lung transplant patient, because what happens in a lung transplant patient, first 2 weeks, there is a chance of infection. The patient lands up with a bronchitis or pneumonia. So the survival rate is very less because you have done a very good job and you should not lose the patient. And the first 2 weeks is extremely vital. So in those lung transplant patients, the commonest organism which gets infected is a pneumocystis infection. So this lung transplant patients, as a part of prophylaxis, we have to give a trimethoprim and sulfamethoxazole combination. Either you can give one dose, one tablet in a day, or 2 to 3 times in a week also it is possible. Some studies also have shown that this lung transplant patient as a prophylactic antibiotic of trimethoprim and sulfamethoxazole can be given for at least 1 year also. So if you get a case of lung transplant patient with a superadded infection, first you have to give a broad spectrum antibiotic, and you have to give a prophylactic antibiotic which should cover for a longer period of time, and that longer period of time should be at least 1 year.
Okay, thank you. We have an audience question. Dr. Asim Mehta, it was discussed just a little while ago, but still, Dr. Anand, if you could once more tell us about EDTA along with antibiotic, does it actually help bypass resistance and how? Dr. Anand, sir.
Sorry, there are some break in the voice. So I'm not clearly heard what you said.
Dr. Asim Mehta from Maharashtra is asking, injection EDTA along with antibiotics, does it help bypass resistance?
Okay. What actually he want to ask? Bypass resistance?
Yeah, means does it help bypass the antibiotic resistance, EDTA?
Okay. Exactly.
Anyone else from the panel? Use of injection EDTA, does it help bypass the resistance?
If I may answer, I think the audience is asking whether if you use EDTA, will all the resistance mechanism be bypassed and can we use it? Basically, that's what the question I understand is. In vitro, the answer is yes, because EDTA helps against drug resistance up to a point. But again, to caution you, we have to see all the antibodies that work inside the tubes inside the lab. do not necessarily mean that they're going to work in the body as well. If we have enough studies to document that they work in pneumonias and every kind of infection, then yes, please go ahead and use it. But as far as I remember last, somebody can correct me if I'm wrong, that the studies were primarily done for UTI infection and then were tried for other kind of infections. So let's not jump directly. If in case there is enough data that will work in drug-resistant organisms, then by all means, yes. But as far as I remember, this cannot be directly used as an empirical choice for drug resistance. So what I mean to say is, suppose a patient comes from other hospital with a report saying that this is a carbapenem resistant E. coli VAP patient, and he's admitted now in your ICU. Can you directly use ceftriaxone on the DDTA? The answer is no.
Okay. So we have come to the end of all our questions, including audience question. And now I would request kindly our panelists one by one to very quickly give your take-home messages that should be there in our practice from tomorrow itself. I would want to ask, first of all, our guest who has logged in from a different time zone and who told us so much, Dr. Farhan, your very quick take-home message for everyone.
Just see if you really need antibiotics. First is clinical diagnosis, clinical inclination, and then use the appropriate antibiotics for the shortest duration of time. Last, one more point about fungal infections. If your respiratory sample is showing candida, please do not use antifungals for those kind of patients. Thank you.
Dr. Ranjan. Take home message, Dr. Ranjan.
You need to unmute yourself, sir.
Yes, sir. Thank you. We are treating patients with empirical antibiotics, and in the meantime, patient is deteriorating, and we are going to increase the antibiotic spectrum. The patient is not responding. So these days, the biofire panel or the multiplex PCRs are very useful because they have a shorter turnaround time, and it can detect the proper organism and narrow down the spectrum of antibiotic, and also can treat the patient effectively. So wherever available, we must use this multiplex PC.
Thank you. Dr. Mitesh.
So basically, according to me, the choice of empirical antibiotics initially is very important because it itself, we can say that we may win half the battle along with a good choice of antibiotics, but at the same time, we must be cautious preventing its overuse, as Dr. Farhan said. So keep the use of antibiotics as limited as possible, as shorter as possible, still being on the point for the particular organism which we are thinking about.
So one very important message which I understood was that we should be smart enough to save the patient in this accident, but also cautious enough to keep some antibiotic for a future accident that may also occur.
Right. Very well put.
Dr. Rahul.
Yeah, you have already summed up the gist of the webinar. So in a healthy patient without comorbidity, a single antibiotic like a beta-lactam would be a good choice, or macrolide. If there is comorbidity in outpatient setting and patient is healthy, you are not patient is not requiring admission, then in a comorbid patient with chronic lung disease, liver disease, or diabetes, kidney disease, then we can go for a combination of antibiotic like a beta-lactam plus macrolide. Fluoroquinolone usually we try to avoid because it is also used in as a anti-TB medicine. If the cultures come out to be sensitive and is fluoroquinolone sensitive, then if it is non-TB, then we can go for a monotherapy with fluoroquinolone.
Thank you. Anand sir, your take-home message.
Actually, my take-home message to the audience is that we should not overuse the antibiotics, number one. As per empirical guidelines, we can use the single drug or the in combination drug according to the condition or the comorbidities of the patients. Besides this, the duration of the treatment should be limited. it should not be more than 7 days. That is recommended in the guideline also. And there are a lot of studies which gives the idea that if we increase the duration of the antibiotic, this will not add any benefit to the treatment outcome. So the duration of the treatment should be limited, not more than 5 to 7 days in cases of pneumonias. If the patient's condition get improved, we can step down the therapies. That is recommended from my side also, as well as according to the guidelines. So if the patients step down from the IV antibiotic, we should not continue for 2 to 3 weeks of the oral antibiotic. That is my take-home message to all. We can stop the antibiotics within 2 to 3 days, so that we can stop the resistance of our limited antibiotics which are available to treat the patients in the current era. Thank you.
Ashwini, sir.
Empirical antibiotics actually is a norm in clinical practice as far as the evidence medicine goes. So it is not about using less antibiotics. It is all about using the correct antibiotics for a correct appropriate of time and for the right duration of the time. So when you start prescribing the antibiotics, you should be extremely smart. You should know the bioflora of the organism, and then you have to focus the patient. So you have to take a right decision at the right time, and the antibiotics duration should be very perfect. It should not be for a lengthy period of time, or it should not be for a shorter period of time.
Yeah, my message is, it's an appeal not only to physicians out there, but people associated with the physicians out there. Please discourage antibiotic without a prescription. Whenever a chronic patient of mine comes to me, I give them a list of oral medicines which are antibiotics, and I tell them that you should never take this without a prescription, whatever may happen. Maybe that is something, if we can legally stop antibiotic sell purchase without prescription, half of the battle against resistance may be won that day. Before we end, I take the opportunity to thank certain people in CCI, Dr. N.H. Krishna, Dr. Narayana Pradeep. They are the founders of this beautiful academic, hardcore academic organization. Dr. Vijay Kumar Chinnam Chetty is the CCI webinar coordinator. Dr. Kirat, Dr. Shivani, Dr. Nitin Abhyankar, Dr. Rajadhar, they are part of the team who plan these topics, these panelists over there. One message to everyone listening to us is, there is no one junior, there is no one senior, everyone here is a star. If you have completed MBBS, if you have done a post-graduation, if you have worked in COVID, all of you are star and all of you are eligible to be part of CCI programs. So if you want to be a part of CCI program, please give us a message. We are just a message, a call away, and we will definitely give you an opportunity in these webinars. I would want to thank the current office bearers, our president, Dr. Ashish Dubey, secretary, Dr. Anil Maske. At the end, our academic sponsor, Cipla Respiratory, for such a wonderful program. Thank you, all the panelists. Thank you, all the audience. A very good night to all of you in India. Good morning, good afternoon to all those anywhere across the globe. Thank you.
Thank you so much.
Thank you very much.
Thank you.
Thank
Thank you so much.